The United Leukodystrophy Foundation presents CTX, presented by Dr. Andrea DeBarber, Dr. Brian Wishart, and John Wolf.
Well, hello everyone, and welcome to this re-recording of the session that was initially broadcast June 26th, and we had some technical issues. So we are, going for a re-recording of the session today. And I'd like to welcome Dr. Wishart. Thanks again for coming and providing a talk. Dr. Wishart's from Mass General Hospital for Children and Harvard Medical School. And he'll be giving a talk today on CTX symptom review and management. After that, I will be providing a talk on blood and urine testing for diagnosis and therapeutic management in CTX. Dr. Michael Gelb from the University of Washington, for June 26th, he did provide a talk on newborn screening for CTX and MLD, the results of the first completed pilot study. Unfortunately, he's not able to join us today, but there is a recording of his session available on the ULF website under the newborn screening panel for annual conference. So if anyone would like to check that out, they can go to the website. And at the end for questions, John Wolf will be joining us. He's the family liaison of the ULF, who is the father of a child with CTX. And hopefully we'll all be able to answer any questions that you may have at the end of the session. And with that, I'll let Dr. Wishart go with his talk.
All right, thank you, Dr. DeBarber. Good afternoon. I'm honored to be here. This has been great, and it's really nice to get to be involved in this community and get going. What I'd like to present today is actually a project that I'm working on with a number of people, other physicians as well as family members, to look at the symptoms that are being seen in CTX and well as the management, and really try to document this and put together some nature of a clinical practice guideline for these types of things. And so we have a couple aims as we're going through this clinical practice guideline work to come up with. Our first is really symptom documentation. There's been a number of studies, and one out of Mass General with Dr. Eichler, who I work with in clinic, had been done in 2016 and had looked at the literature really prior to 2015 going through. And so what we're hoping to do is expand our literature review and look back at those new papers that have come out since 2016 through 2019, which has been fairly numerable. I think we had originally somewhere in the 80 number of range articles that we originally looked at, and with exclusion criteria brought it down to around 50. So we'll be looking at the most recent articles that have come out around CTX. And what we're looking at for symptoms is really their presence and what age of onset we see these in. And I'll show you graphs of how we'll plan on presenting this and how we'll start to organize this information, but it's really going to be kind of a cumulative incidence function graph where we look at, how many percentage of patients are seeing it when they're children, when they're adults, when they're 30, 40, 50, so on and so forth. And we'll go through to have a good sense of what we expect for CTX, which will help us down the road, I think, when we're starting to think about therapies and other things. One of the other aspects that we're going to look at is psychiatric symptoms. This has been looked at somewhat in the population, but it hasn't really been too granular of how they've looked. It's been very general in the literature from what we've seen. And it is one concern we have as we go through the literature. Whatever is out there is what we have to work with. So we're hoping that we'll see more specific symptoms in the new articles and be able to put those together to have a larger group that we can talk about. We'd also look at how these patients are being treated and whether they're being used on medication or anything like that, if they're doing behavioral therapy, what's working when they're starting this, and really putting all that together. Once we have the symptom documentation, we're hoping to go through what management is being used for these patients and look through the charts and literature of our patients in our group, as well as with outside organizations and outside literature of what we can see. And we'll break this down, particularly in neurologic and non-neurologic symptoms, but we'll also obviously be looking at those psychiatric symptoms as well. One of the big important parts of our clinical practice guideline has been involving the community and having family members involved from the beginning of what we should be looking at, what we've been missing in previous studies, and what we're hoping to pull out of this type of work. One of the things that they brought up, we have, I think, two family groups, two parents that are working with for two different families in our group. And one of the big things has been some of the psychiatric symptoms and behavioral issues, attention issues, and different things like that. It's an autism type presentation. And so, we're hoping to look through this, because what we've been described as when we talk to these families is that a lot of these symptoms early on are fairly vague. They're disregarded by the general practitioner because, they have to be. These are relatively common things when you start talking about attention issues and social concerns, and likely don't lead to CTX in almost all cases. But it's not until these children are older and their symptoms become more severe that we start to see these diagnoses. And since they're so early and CTX, and they don't start until they're in adolescence, what we end up seeing from the families that they've heard about psychological problems, cognitive declines that were attributed more to behavioral issues and learning disabilities, but it might be something that we can use as an early set point of saying, okay, this is starting to be symptomatic, particularly if we have some newborn screening and that sort. So one of the things that we talked about from the moment we started this project was making sure that we identified the gaps in our knowledge. We really want to make sure that as we're going through this, we're thinking about future research that can be done, future projects that need to be addressed, and things that we just are not seeing in the literature that we may expect to, whether that's from our experience with other illnesses, other leukodystrophies, other diseases in general, or from our family component and what they're seeing in their children. So again, we'll go over those symptoms for our neurologic, non-neurologic, and psychiatric symptoms. We're going to review our management strategies and options. We also are going to expand our case series. So in that previous paper that I had shown on the other slide, we had reviewed about 5 patients, and I think we now follow about 9 patients in our clinic. And so we're hoping to expand that case series as well. And then again, those gaps in the knowledge. So this is a fairly comprehensive and generally what we've been hearing as we've gone through the literature, as we've talked to the families and the different symptoms that are out there. This is what we're looking for. You can look at the neurologic. These are fairly classic symptoms. So things that come up with cortical spinal tract injury, spasticity, weakness, that we describe as hyperreflexia or a positive Babinski sign. These are the types of things we're looking for in the literature as we go through. But we're also looking at gait difficulties, ataxia, Parkinsonianism. And, with my background, I'm a pediatric physiatrist by training. I also see some adults. Gait and bracing is really, tone management is really the heart of what I do outside of the leukodystrophy world. And so I'm hoping to narrow down and really become a little more granular in terms of how these patients are struggling in their gait, what difficulties we're seeing, and what we can potentially do for that. The psychiatric symptoms, again, in the past, they've really just been reported as psychiatric symptoms, and we don't know exactly what these patients are seeing. And sometimes I worry with that we're missing some of the more subtle findings, such as autistic features, attention issues, learning difficulties. And when we're looking at kids, I think that's more of a likely presentation than some of the other things early on. As kids get older and they get into their adult years, we may be seeing these more severe symptoms, and we'd like to document that so we know when we're seeing it, when to expect it. But I think we need to also be looking very a little bit more subtly at some of those other features early on in life. We'll look through some of the non-neurologic symptoms as well, some of the classic things that come with CTX, such as xanthomas, cataracts, diarrhea. And then there's some other things that came up when talking with families, such as this exercise intolerance or fatigability, osteoporosis. There's other symptoms that come up and often get linked in with just death and when these patients are dying. But what we'd like to do is also delineate when these types of symptoms are being seen, such as cardiac disease and respiratory failure. And again, our gaps, back to that, bowel and bladder is something that we don't see typically in the literature and something I'd like to make sure we address. Excessive drooling, if this has become an issue, I have a number of patients that we see that struggle with their communication and have had issues with sialorrhea. And then dystonia, just to expand on some of the movement disorders and tone issues that we see in patients. So this is about how we'll present it. These are some of the more common symptoms that we see. What you see here is 2 different graphs. The red is the early onset, and then blue would be the scenario with the latest onset, and that's just in case there's a range within any of these papers when they're describing the patients. And then we'll put through, as they go through and more patients get it, we'll see what percentage of patients we expect to see with the disease and when we start to see them in their life. And these are some of the more subtle things. Some of these I do worry about whether or not we're capturing everything, particularly because a lot of this has come from retrospective studies, but speech changes is something I see commonly as patients are getting older, and to have only about 30 to 40% present in their 60s, I think is of question, and probably has something to do with treatment versus non-treatment and all of those things. But I think it's something that we need to make sure we address. Again, our non-neurologic symptoms, you can see there's some questions when we look at the data, such as diarrhea, that only 20 to 30% of these patients have it. Is that ongoing? Is that chronic? I'd like to break that down a little bit further, and then I also go through. And again, this is all we have from that previous study of the review of the psychiatric symptoms is just their psychiatric changes at some point. And so I think we need to break it down and parse it out a little bit clearer when we're going through this. The second part of our review is going to be looking at management, and there's the different types of management that we think about. Medication is an obvious aspect of things. We'd like to look at the timing when these patients are getting started on this, what dose they're getting, if they're getting a response. This is also going to be looked at in a different clinical practice guideline, so we likely will not be going too in depth in terms of the CTX specific treatments, such as CDCA and other medications. But I would like to do this with some of the psychiatric medications, tone medications, anti-epileptics. You see a lot of overlap, and there's certain medications that can do more than one thing, particularly in these three categories. And so going through and kind of delineating when they're starting, whether they were able to tolerate it, and if not, for what reason. These are kind of our lofty goals of this review, and we'll see what the literature has for us, but hopefully this is something we can come up with. The other aspect, and this is my physiatric background in physiatry or rehab, we'd like to look at what non-pharmacologic aspects are being put in for these patients when they're doing therapy. Are they starting it early in life, or is it more just goal-oriented that we're focusing on, oh, we're having trouble getting our pants on, or another specific ADL that we're going to really target with our therapists, or are they doing it for more maintenance, more ongoing care? And again, same thing, response, tolerance, whether they're doing well with it, whether they're able to get through it. The other thing with that communication aspect, I'd like to look at when and if these patients are being referred to augmentative communication and what types of devices they're using and that sort. Bracing, since we have this spasticity, we have issues with our gait and that sort, I think is an important aspect. And I'd like to look at what types of stuff has worked for patients in the past. And then again, with xanthoma treatments, I'd like to look through what we're seeing and see if we can't look outside of CTX and see if there's any other treatments that are being done for these patients. And report on that. And again, we're going to be hoping to document reversibility of the overall disease as we look at these oral medications, and then again, response to treatment for each individual symptom. And again, back to the gaps in knowledge, which I think is a really important part of what we're going to be looking at and how we're going to be going through this from the outset, and not doing this on the back end thinking, oh goodness, what did we miss? Why didn't we have that in there? But really thinking about it from the beginning. When we're done with this, we hope to put out a number of publications related to it. One would be that clinical practice guideline looking at the symptom documentation and different management strategies. We'll also be working with our family with this and putting together a family companion of that CPG, something that's a little bit more directed at our patients and our families that are working with those patients on a day-to-day basis. I'd like to delve in and see if we can't look specifically at those spasticity management aspects, as well as some of the gait difficulties and what patterns we're seeing at different timelines within these patients' course, and what they're doing for that in terms of the bracing and what's working, what's not. Same thing with physical, occupational, and speech therapy. What are they doing? What are they doing it? Which one are they doing at different times of their life, and why are they using that stuff? And then finally, looking through our psychiatric presentations, what interventions are done and what needs might be out there. So I wanted to say thank you to Hunters Hope. They're the ones that are funding our research there, and Dr. Eichler is the head of our group at MGH. And thank you so much to the ULF. So if there's any questions or anything for me, otherwise I will pass this back to Dr. DeBarber, and I think we're doing questions at the end, if that makes sense. Thanks.
Thanks very much, Dr. Wishart. That was a great overview of the clinical signs and symptoms of CTX. And so with that, I'm going to switch gears now and talk a little bit about blood and urine biochemical testing for the diagnosis and therapeutic management in CTX. So my name is Andrea DeBarber, and I oversee the clinical diagnostic testing laboratory, OHSU, that specializes in diagnostic testing for CTX. Let me just. And so these are my funding disclosures. And so because I would like to talk about blood and urine testing for CTX, I really want to talk about the major biochemical pathway that's disrupted in CTX. And this is the main neutral pathway to the bile acids, chenodeoxycholic acid and cholic acid. And also about the intermediates that are elevated in CTX when this pathway is disrupted, or these biomarkers for disease, as we call them. So in CTX, the enzyme activity that produces cholic acid and chenodeoxycholic acid, the sterol 27 hydroxylase, is disrupted so that these bile acids cannot be produced. And in this pathway, the bile acids are produced from cholesterol, and this pathway is initiated by a 7-alpha hydroxylation in a couple of steps to produce this molecule here, 7-alpha C4. And this is 7-alpha hydroxy 4-cholestin 3-one. And in a number of steps, this is converted to chenodeoxycholic acid. And as I said, this activity is deficient in CTX. 7-alpha C4 can be hydroxylated again at the 12 position to form 7-alpha 12-alpha dihydroxy 4-cholestin 3-one, or 7-alpha 12-alpha C4. And normally this is converted to cholic acid, but again in CTX this pathway is disrupted. And so 7-alpha 12-alpha C4 can be hydroxylated further to form these bile alcohols that are elevated in CTX. And they're tetrols, they have 4 hydroxy groups, or pentols, 5 hydroxy groups. And then they normally, what's called glucuronidated, they have a glucuronide handle added to them, which is a polar that allows them to be excreted into the urine. And so also elevated in CTX is cholestanol. So this that many of you may be familiar with, this molecule is elevated and formed from 7-alpha C4. So what normally happens is this pathway is regulated by the amount of chenodeoxycholic acid that's present. And so when this pathway is working and there is enough chenodeoxycholic acid, it provides feedback inhibition to shut down this step, this initial 7-alpha hydroxylation of cholesterol. And when this is deficient or missing in CTX, this doesn't occur. And so this pathway is really upregulated. And along with the blockage in the formation of chenodeoxycholic acid and cholic acid, very high levels of these intermediates or biomarkers occur. And so the first one that I will talk about today is cholestanol. And so that's more routinely been used as a biomarker or diagnostic biomarker for CTX. And so this is a widely used blood test for CTX, and the normal concentrations are normally between 1 and 5 micrograms per mil. In a large study of over 333,000 individuals, they showed that the 99th percentile cutoff for this was around 5.4 micrograms per mil, although there have been reports in the literature of levels up to around 7 micrograms per mil, normal levels. And so the lab here at OHSU, we use 10 micrograms per mil as our diagnostic cutoff, above which we say the level of cholestanol in the plasma is consistent with CTX. So there isn't one issue with cholestanol, that it's what's called a low specificity marker, because it can also be elevated in other types of liver disease. And so CTX, as Dr. Wishart mentioned, is a progressive disease in which the neurological deterioration over time is associated with the accumulation of cholestanol in the central nervous system. And so treatment in this disease is actually replenishing the chenodeoxycholic acid that's missing. And then this shuts down this pathway and prevents accumulation of all these intermediates. And so the goal in therapy is to shut this pathway down, and this is measured in the form of the levels of cholesterol. So what the physician wants to see is the cholesterol levels going down to show that the therapy is effective. Chenodeoxycholic acid is considered the gold standard treatment. And so in children, the dosage is normally 5 to 15 mg per kg per day. And in adults, 750 milligrams per day. Normally the physicians send the samples to the lab at baseline to measure the blood cholesterol, and then every 3 months for about the first year after treatment's initiated, and then every 6 to 12 months after that to make sure the levels of cholesterol are controlled in the blood. And it can take quite a while for the cholesterol to come down. Sometimes it even takes around 6 to 12 months for the cholesterol to get down to what's considered normal levels after chenodeoxycholic acid treatment is initiated. Dose adjustments can be made based on body weight and blood cholesterol concentration, and often it can be noted difficulty with treatment adherence can be indicated by plasma cholesterol that's not very well controlled. So the second set of biomarkers that I'd like to discuss today are these bile acid precursors, the ketosterol compounds, the 7-alpha-C4 and the 7-alpha-12-alpha-C4. So as I mentioned, 7-alpha-C4 is the initial step in this neutral bile acid pathway, and it's considered to be a measure of the rate of synthesis of bile acids. And so in CTX, this has been levels of 7-alpha-C4 in untreated CTX have been shown to be very high because this pathway is not being controlled because of the lack of chenodeoxycholic acid. And our lab was very interested in bringing to the clinic as clinical tools for the physicians newer tests for CTX that didn't have the same limitations as cholesterol, that were more specific for CTX. And so we were interested in developing testing for 7-alpha-C4 and 7-alpha-12-alpha-C4. So 7-alpha-12-alpha-C4 had previously been shown to be present at very, very low levels normally. So normally it's not really detectable. It's present at less than 1 nanogram per mil. And so there was one report in the literature back in the 80s that took tissue, liver tissue from CTX, untreated CTX patient, and showed that this 7-alpha-12-alpha-C4 was 100-fold the normal concentrations. So we anticipated that this would be a very good diagnostic marker for CTX. And so back in 2014, we actually had a sample that was submitted to the clinical diagnostic lab. And this was from a 57-year-old female who had cataracts, one of the symptoms of CTX, and a xanthoma. So you can see here the xanthoma on the Achilles tendon. So the clinical phenotype was very characteristic of CTX. And we measured the plasma cholesterol and determined that it was around 8.4 micrograms per mil. So this is at the very high end of the normal range, but lower than our normal diagnostic cutoff that I mentioned was 10 micrograms per mil. And so at that point, we measured the 7-alpha-C4. We developed assays and measured the 7-alpha-C4 and the 7-alpha-12-alpha-C4. And you can see here, both of them were highly elevated in this individual. And if you look at the 7-alpha-12-alpha-C4, we measured in 20 unaffected individuals and were able to replicate in the literature and show that the concentrations were very low, less than 0.8 nanograms per mil. And in samples from 10 known CTX untreated individuals, the concentrations were very high, with a mean concentration of 1,548 nanograms per mil. We were able to show for this patient that so for this patient, the concentration was 1,548 nanograms per mil. And the range in 10 samples from CTX untreated patients was 57 to 2,420 nanograms per mil. So all of this biochemical evidence pointed towards this case being CTX, and it was also then demonstrated by genetic testing that this individual had pathogenic variants in the CYP27A1 gene that caused CTX, that were previously demonstrated to cause CTX. So we now offer this testing clinically, and this is what one of the reports from the lab looks like. And so the nice thing about this testing, as I mentioned, so we show here an example of an individual that has high cholesterol. So if you look in the bottom right, the concentration in this plasma sample is 2.1 milligrams per deciliter. So that's equivalent to 21 micrograms per mil. So well above our 10 microgram per mil cutoff. But when we measure the 7-alpha, 12-alpha C4, it's less than 10 nanograms per mil. So it's very low. So the interpretation for this sample will be that this was some sort of liver disease, maybe cholestasis in this individual, but that the biochemical evidence is not consistent with CTX. So this testing is more specific than the cholesterol testing. So this is something that we offer. And so one thing that we found was that we don't necessarily have to have plasma samples to be able to do this type of test. A spot of blood can be collected on a piece of filter paper, and it could be shipped to us. And a lot of times it's a lot easier to ship the dry blood spots. You know, they don't have to be frozen, and, you know, it can... even the shipping period could be, days and weeks rather than overnight shipping. And so we were very well able to measure the 7-alpha, 12-alpha C4 in the dried blood spots as a diagnostic test for CTX. And so this means physicians can collect these samples in the office, you know, rather than having to have a blood draw. You can have a finger prick and collect these dried blood spots and send them from diagnostic testing. And so we actually have a sponsorship from a company to provide free diagnostic testing from the dried blood spots. You can search this online, and this is available for eligible patients, with symptoms consistent with CTX. So that's something that the lab now offers. And so finally today, I'd like to talk about the bile alcohols. So these biomarkers that are also elevated in CTX. So the tetrol bile alcohols or the pentol bile alcohols. And so first, I'd like to talk about the tetrol marker. Back again in the 1980s, it was demonstrated that one of these tetrols, so these come in different flavors or different isomers, one of these tetrols was reported to be the highest concentration tetrol isomer present in CTX blood. And this is known as 3-alpha, 7-alpha, 12-alpha, 25 tetrol. And so in this test, this tetrol is normally present as its glucuronide conjugate, as I mentioned. But in this test, they actually cleave the glucuronide off and measure the tetrol in its free form. And then in another paper from the lab of Quesada in 1991, they also showed that this tetrol was very elevated in untreated CTX patient with a mean value of around 3,487 and very low in controls, around 4.6 nanogram per mil in controls. And it's also fairly low in cholestasis. So again, another good marker to be able to differentiate liver disease from CTX. And then in the lab of Kuramoto et al. In 1995, they actually identified in CTX bile the predominant glucuronide species. So not only the tetrol, but conjugated to the glucuronide also. And they showed that the glucuronide was conjugated at the 3 position of the tetrol. And then in a paper in 2013, we actually showed that this is the main species present in CTX blood as well. So the tetrol conjugated at the 3 position. And so this marker, biomarker, has shown much promise in being able to screen newborn dried blood spots for CTX. And so we were able to measure this in the dried blood spots and provide reference ranges to again show that in blood, the 3-glucuronide molecule is very elevated in untreated adults and children, and also that it can be used to differentiate CTX newborns from unaffected newborns. So it's a very promising biomarker for newborn screening. And so finally, today, I'd like to talk about the pentols that are present in CTX urine. And so again, back in the 1980s, it was shown that the main pentol species was 5-beta-cholestein, 3-alpha, 7-alpha, 12-alpha, 23, 25 pentol. These are the positions of the hydroxy groups. And I show a picture here of the compound. And that the levels of this were very high in untreated CTX patients. And then in 1986, in the lab of Shimadzu et al., they were able to show that the form of this, the 23S form of this, so there are 2 positions here for this hydroxy group, the R and the S isomers. Well, the 23S isomer was the predominant isomer present, and that this decreased by about 98% after 6 months of treatment with chenodeoxycholic acid. So as I mentioned, our lab really wants to bring these tests to the clinic, these quantitative tests, and make them available. And so we were able to have these standards synthesized of the 23S pentol and the 23R pentol. And we were able to replicate the data in the literature and demonstrate that the 23S pentol was the most elevated pentol, and it was present, at tens of thousands of nanograms per mil compared to the control levels, which were 50 to 173 nanograms per mil. So it was a very good diagnostic marker in the urine for CTX. And so again, with this assay, we cleave the glucuronide group because this makes it easier to measure the 23S pentol in the urine. And so we're also able to offer this as a clinical test. And so we don't know yet whether these new tests, how useful they'll be for therapeutic monitoring in CTX. We're still in the process of generating that data on how they compare to cholesterol. So, first and foremost, I'd like to acknowledge the CTX patients, participants and their families who've, provided samples for this research over the years. I'm very grateful. And then my lab members, and you can see the lab here now. This is the new reality that we deal with where everyone is remote interacting, and then the bioanalytical shared resource core at OHSU that lets us use some of the instrumentation, the analytical instrumentation, and Dr. William Connor, who's passed away, and Sonia Connor, who first began this work at on CTX at OHSU, and over the years, Dr. Steiner and Dr. Duell, who've also collaborated and participated in this research, Retrofin for funding and help making some of these analytical standards. Thank you to the ULF for allowing me to talk about this today. And with that, I'm going to change gears. And because we have a little bit more time available today, I'm just going to give another short talk. And so this short talk is a presentation to provide an update on another systematic review that's being performed. And we hope this review has a focus on diagnosis and treatment in CTX, particularly in infants. They may be potentially identified in the future through newborn screening. Next slide, please. These are the individuals that are collaborating on this project, and the project's being led by Dr. Shailesh Patel at the University of Cincinnati. And the work group consists of other experts in the diagnosis and treatment of CTX, including physicians Dr. Austin Larson and Dr. Robert Steiner, as well as Christy Piper and Dr. Patricia Hain, who's Deputy Director of the US Cochrane, Colorado Affiliated Center. And as I mentioned, I oversee the diagnostic lab at OHSU that specializes in diagnosis of CTX. Next slide, please. And so before I share with you the questions that the working group has developed for the systematic evidence review, I'm just going to, again, talk in a couple of slides, change gears and talk about the pathway towards newborn screening for CTX. Next slide, please. Okay. And so, my apologies, the text here is very small, but in brief, in January 2014 was the first demonstration that CTX newborn dried blood spots could be identified using LC tandem mass spec detection of the 7-alpha, 12-alpha C4 biomarker that I talked to everyone about. And that was from my lab back in 2014. And then in July 2016, there was a meeting hosted by the ULF to discuss submitting the CTX nomination for consideration for addition to the recommended uniform screening panel of disorders that screened for in newborns. In May 2017, it was demonstrated that CTX newborn dried blood spots can be identified using the peak area ratio between tetrylglucuronide species that I talked about today and taurochenodeoxycholic acid using MSMS, so without liquid chromatography. And this was from the lab of Vaz et al. In 2017. In August 2018, the nomination was submitted to the Secretary's Advisory Committee to consider CTX for addition to the recommended uniform screening panel. And this was submitted by a group of stakeholders, including advocates, patient advocates, families, physicians, and researcher scientists. So in November 2018, there was an in-person Secretary's Advisory Committee meeting held in Rockville, Maryland. And this was attended by John Wolfe and Dr. Steiner, myself, and some of the other CTX families, where the CTX nomination was discussed. And the advisory committee tabled the nomination until additional evidence could be provided. So they really want to see additional evidence that I will talk about in the next slide. So in November 2018, the primary tetrylglucuronide species in CTX newborn dried blood spot was confirmed to be the 25-tetrol 3-conjugated glucuronide. So this is the tetrol that I described in previous slides, and the concentration ranges in untreated CTX newborns and adults was determined in a quantitative manner using isotope dilution LC tandem mass spectrometry. And then here recently in June 2020, very excitingly, data from the largest study to date, more than 32,000 Washington State newborns, dried blood spots were screened using a similar methodology, so isotope dilution LC tandem mass spec technology, and this demonstrated that this glucuronide, tetrylglucuronide biomarker, or the ratio of tetrylglucuronide to taurochenodeoxycholic acid, could identify a positive CTX sample with a 0% false positive rate. So this was a clear demonstration that we can screen newborn dried blood spots and identify positive CTX samples. So In addition, some other activities that are going on in terms of supporting the newborn screening are that beginning this fall in 2020, a large prospective pilot study called New York State Screen Plus will begin screening New York State newborns using the similar methodology, isotope dilution, LC tandem mass spec analysis of CTX biomarkers. And this will be a study that screens identifiable newborns, a prospective pilot study. And so one of the things the Secretary's Advisory Committee wanted to see is that they wanted an identifiable newborn identified through this type of prospective pilot study. Also, in the fall, this fall, the Netherlands has an ongoing study to screen 20,000 Dutch newborns using tandem mass spectrometry, so without the LC portion. So in the Netherlands, they're one step ahead of us here in the US, because the Dutch Health Council has actually advised to add CTX to the Dutch newborn screening program upon availability of a suitable screening method. So they have identified CTX as a candidate disorder that should be added to the newborn screening once there is a test available. And so what evidence does the Secretary's Advisory Committee would they still like to see before we can resubmit the nomination for CTX? Next slide, please. And so this is a copy of a letter that was sent to the the group that submitted the CTX nomination from the Secretary's Advisory Committee. And so they do indicate that they recognize CTX as a medically serious condition that deserves thorough consideration, and that there is appropriate diagnostic testing available for CTX and a treatment, and that there are defined treatment protocols. Next slide. And so one of the pieces of, actually, sorry, it's the previous slide. One of the pieces of evidence that's still missing is a case definition. So they would really like clarification regarding what is considered a true positive case of CTX and the inclusion of relevant biochemical markers or biomarkers if applicable. With references or documentation of consensus amongst experts in the field provided. And then one of the other things the committee would really like to see is in terms of clinical utility. They're very interested in understanding how screening can inform treatment and how early treatment can impact health outcomes. So are is the genetic testing or the biochemical testing result, is that useful to guide treatment for CTX, is what they're asking. Next slide, please. Thank you. And so these questions were really developed for this systematic evidence review to try and help provide this evidence that the Secretary's Advisory Committee is looking for. So our first question is, what are the minimum diagnostic criteria to define a true case of CTX? With a sub-question about biochemical testing and genetic testing together sufficient to diagnose CTX? Next slide. So the second question for this evidence review is that should CTX therapy be guided by genetic or biochemical disease markers? So the sub-questions are, do specific CYP27A1 genetic changes predict the outcome? If so, do these warrant specific therapeutic strategies? And the second sub-question, do levels of biochemical markers at diagnosis predict outcome? And if so, do these warrant specific therapeutic strategies? Next slide. So question 3 is, what is the effectiveness of therapeutic intervention in CTX to prevent disease progression? with a sub-question, what is the effectiveness of therapeutic intervention to normalize the aberrant biochemistry? And the second sub-question, if the biochemistry is not normalized, are health incomes impacted? Should there be a specific biochemical target as the primary goal of treatment? So hopefully this question will help provide evidence to determine, if a newborn is identified without clinical symptoms, what is the timing of therapy? Should it be initiated immediately? Is controlling the biochemistry in CTX associated with controlling the progression of the disease? Next slide, please. So question 4 is, does the timing of the treatment initiation, including pre-symptomatic treatment, impact health outcomes? With a sub-question, should the clinical disease stage and patient age impact the choice of optimal therapy, whether monotherapy or combination therapy? Hopefully again to provide evidence to help answer these questions from the Secretary's Advisory Committee. Next slide, please. And the final question for the evidence review will be, are current CTX therapies safe? With a sub-question, what are reported adverse events and their frequency and severity? Next slide, please. And so this systematic evidence review protocol will be registered at the Prospero site, which is an international prospective register of systematic reviews. I would also like to acknowledge, support from Hunter's Hope in the development and the work on this systematic evidence review. So at this point, I think we're open for questions.
All right, everybody watching on YouTube, thank you so much to our presenters today for their presentation. So if you're watching on the YouTube side and you have any questions, please feel free to enter them in the chat box, and then I'll pass them along to our presenters today.
There is one that came in earlier. Did you see that one, Keely? From Vanilla
In the
Pots?
meantime, do we have any updates on, John, if I can pick on you for a second, are there any upcoming advocacy opportunities that people want to become more involved in advocacy efforts? Are there any opportunities coming up that people can become more involved?
Not currently. Can you hear me?
Yes.
Okay. I was referring to a question. It looks like it did pop up there. So no, there is currently not any additional opportunities right now. We're looking into some of that, and I'll keep you posted.
Great. Okay. And then if you want to go ahead, let's see. Trying to keep up, Dr. DeBarber, do you know if just one of the metabolite, oh my goodness, I'm not going to try to say that, are what cause myelin problems, or do we just know that the pathway is broken? I apologize. I do not want to butcher those words.
So currently that's not known. It's thought that these intermediates, these bile alcohols and other intermediates that accumulate, they interfere with the blood-brain barrier and cause that to be more permeable. But not enough research has yet been done to figure out, exactly the cause of the cause of this in CTX.
Okay. And it looks like a couple more questions are popping up. Where would it be possible to view the webinar materials offline? So the webinar materials, Dr. DeBarber and Dr. Wishart can email their PowerPoint presentations to the ULF office, and then we can upload them onto our website, and you can download them from ulf.org. We have an educational materials portal where we can make those presentations available. Next question is, would it be more useful to monitor response to the CDCA dose with CDS instead of the plasma cholesterol level?
As I said, the lab is accumulating the data from samples that come into the lab, or, that we have here, they're available for research testing. And we think some of these biomarkers that are directly in this pathway act more rapidly to the treatment of chenodeoxycholic acid than cholesterol does. As I mentioned, cholesterol can take quite a while to come down to normal levels. These other markers may be more useful for a more rapid titration of the dose effect in chenodeoxycholic acid. But we don't know this yet. So we're trying to generate that data to see if some of these may be more useful or complementary biomarkers to monitor therapeutic efficacy.
All right. Next question is from Sue Stewart towards Dr. Dr. Wishart. It is too difficult for my son to travel to MGH, but I am interested in having input on a variety of Dr. Wishart's questions. How can we be involved?
Yeah, Sue, I think that'd be great. Maybe we can send you my email offline or something, that you could send me some information and we can connect that way.
Absolutely. Sue, I will forward Dr. Wishart's email to you once the webinar has ended. And then Carol Bauer says, my brother, age 65, has been treated with CDCA for 15 years with progression of disease such that he now has cortical blindness. Hence my question, re the DBS test. Okay, so it looks like Dr. DeBarber had already addressed that question. So if there are any additional questions that people would like to ask, otherwise, we'll give them a couple of minutes to see if anything else pops up. I apologize, it looked like my feed was slow, so when I refreshed it, I had all these questions pop up on my screen. Okay.
I had a comment / question.
Yep.
So in regards to, and Brian, you may have touched on this. There was a lot of material there, and this may be something that's part of the study you're doing. Is there any effort to understand the correlation between effectiveness of the treatment in relation to the biochemical response, and then dovetail into that the start of treatment compared to age of onset of symptoms and the age of that, and the severity of the symptoms that are accompanying that scenario?
So I'm not necessarily looking at any very specific biochemical aspects of it. I think we're looking purely at kind of the clinical side of things. I think it's a good question of, onset versus kind of delay or time to treatment. And then, what we do want to make sure we address is reversibility, that if we are starting to treat, are we seeing changes? Are we seeing improvement, or are we seeing complete reversal of that type of symptom? So I think from my standpoint, we're really coming at it much more from a clinical aspect of things. And again, it is solely retrospective, so we're unable to kind of add in any blood tests, but I think it's something that should be kind of thought of as we move forward.
And then maybe to follow up, Andrea, if you could respond. So that's one of the criteria, I think, right, for the nomination is to understand some of that. So do you know of any efforts to, and I want to reference some anecdotal, stories I've heard over the years where the biochemical response is what it should be, but the clinical response is not reflective of that.
And so, we think these are really important questions. And so this is why we're working on this systematic evidence review that will hopefully, help be able to provide some evidence from these questions. And, I feel like the evidence review is complementary to the one that, Dr. Wishart is working on with the families. And so, the evidence may or may not be out there but we're going to do our best to try and review this and put the evidence that's currently out there together in this review.
Thanks. I want to give a quick shout out to George Bryce. I see him chatting over there. Him and I met many years ago. I think our very first CTX meeting. So nice to see you in there, George.
All right, and speaking of George, George wants to throw out, would you be interested in my testing results? I have been treated for 20 plus years. I'm guessing 20 plus years. Mine affects my nervous system, spinal cord, and finally, or how can I help with your studies?
So at OHSU, we have an ongoing study, where we're looking at the biochemistry in CTX. And George, if you search OHSU and DeBarber, you should be able to find the website, and there's information there about enrolling for the research study. And if you're interested, you would be able to enroll in that, and that would be helpful to look at the biochemistry. I wanted to mention one last thing as well. So, as I said, unfortunately, Dr. Gelb wasn't able to join us today, but he gave a very exciting talk with this very exciting data about identifying the CTX newborn and showing that this screening methodology actually works to screen a large number of newborn dried blood spots. So if anyone's interested, please do go and look that up and listen to his talk. This is very exciting data that really supports the nomination of CTX to the recommended uniform screening panel as well.
And I think from our standpoint, we're unfortunately not enrolling any patients. Ours is just retrospective. So hopefully in the future, we can do something along those lines. But thank you.
All right. Well, thank you so much to everyone that joined us on the YouTube side to watch this live webinar on a Thursday afternoon. And thank you so much to Dr. DeBarber, Dr. Wishart, and John for joining us. And this recording of the webinar will be available by next week on the ULF website. So please keep an eye out for that. And thank you for joining us for this re-record. And we look forward to seeing everyone hopefully in Chicago next year.